Good day, everyone. Thank you for the opportunity to speak to you today. My name is Debraj Shome. And I shall be speaking on eyebrow lift mechanics today. This talk is following all the wonderful talks which have already been spoken about by the various authors today. And so from that perspective, this will be a repetition of some of the talks which have already happened. The eyebrow and the eyelid are very important. And really to discuss all of this in 10 minutes is really difficult, but I'll try and do the best I can. In general, we all understand that there are distinct differences between the appearance and the topography of the male and the female brow. In the females, the brow tends to be over the orbital ridge, the superior orbital ridge, and the lateral portion of the brow tends to be higher than the medial portion of the brow. Whereas in men, this line where the eyebrow is located is at the superior orbital ridge, and both the medial and the lateral portions of the brow are almost parallel to each other. So this is the big difference. So that is what we mean by saying masculinizing a feminine brow and feminizing a masculine brow. By knowing the gender of the person and ascribing the brow therein, we can actually define a lot of traits and give a lot of traits to the face and the way the face ends up looking. As we are probably aware, the procerus, the corrugators, the depressor supercilii, as well as the orbital part of the orbicularis oculi are all the depressors of the brow. So as there is animation in this area, the brow is being pulled down further and further down, and the only elevator to the brow is really the frontalis muscle. So in general, unless and until the strong depressors are not neutralized, it's very difficult to use neuromodulators to get the brow to go up. And also, since the frontalis is more or less located in the central 2/3 of the brow, and there are not too many fibers which are in the lateral part, there is essentially no brow elevator to the temporal brow. And that is also one of the major reasons that temporal brow ptosis is a very common aging change. When we think about the anatomy, it's actually the eyebrow-eyelid continuum. And we are aware that the eyebrow and the eyelid transition seamlessly into each other. And then we have the retroorbicularis oculi fat and the postorbicular facial plane, as well as the preseptal fat in Asians. We are aware of this anatomy already. In general, mother gravity is ever so kind. And as we grow older and older, our brows are being pulled down continuously by mother gravity. And so as a result of which the eyebrow is coming down with age. What also makes this worse is the fact that on a daily basis, the depressors of the brow are going ahead and causing the brow to come down by pulling on them very strongly. And this in turn, this descent of the brows adds significantly to the aging of the entire eyebrow-eyelid continuum. A ptotic brow caused by these gravitational changes or the loss of volume or even the depressor-related muscle activity can cause apparent increased skin redundancy and fullness in the upper sulcus and especially the temporal eyelid. We understand that dermatochalasis is a condition where there is increased skin in the upper eyelid. And so as a result of which the uninformed or the underinformed may go ahead and recommend blepharoplasty surgery for each of these patients. However, in a majority of these patients, you actually have to elevate the brow level and see where the brow lies. If the brow has descended from its original position, obviously it will lead to an increase of skin in this particular area, in which case removing the skin in the eyelid area is not the answer. Ultimately, think about it like this. If the brow keeps coming down and you keep removing skin in the eyelid area, at some point, maybe the eyebrow and the eyelashes will come and almost be adherent. That's not symmetry or that's not aesthetics. So from that perspective, understanding that dermatochalasis in older age groups is caused by brow descent is the first step to identify brow descent, and any eyelid redundancy of skin has to be evaluated by first putting the brows in the normal anatomical position as they would have been when the patient was younger. These are some of the papers which have talked about some of these phenomena that I'm talking about. And in general, it is clear that the eyebrows and the eyelids have to be considered as one aesthetic unit. You cannot look at one without taking the other into account, and you should not be evaluating the eyelid skin without looking at earlier photographs, which demonstrates brow descent and shows us what the anatomical position of the brow used to be earlier. When we think about the brows coming down and how that impacts the eye shape and size, and how that also impacts the amount of skin on the eyelid, it becomes important that eyebrow lifting is important. And keeping the eyebrows up will make the periocular area look more rested under most circumstances. We look at brow lift as being non-surgical or surgical, and you could use the following modalities in non-surgical and some of these other modalities in the surgical brow lifts. Now, first, let's look at the non-surgical brow lift. This is something that we do a lot in our practice. It's a chemical brow lift using botulinum toxin. But you must remember that unless and until you use the botulinum toxin to paralyze or reduce the activity of the depressors which lie in the central axis, just using a little bit of botulinum toxin below the tail of the brow in trying to get the brow to kick up will just not work. Unless the depressors lose their action, the elevators will not be able to elevate the brow, and that's the first step in a chemical brow lift. Into the procerus and corrugator supercilii complex. Look at this particular video. After assessing the patient in both static position as well as dynamically using the facial muscles, we see where the lines are and then go ahead and inject accordingly. It is very, very important into the procerus and after we have analyzed and we've put in the markings for the procerus and the corrugator supercilii, we go ahead and actually inject the botulinum toxin. In this case, there is 4 units of botulinum toxin being injected per 0.1 ml of the diluted solution. Now we will move on to injection of the glabellar lines. You can see at every point we are asking the patient to animate and actually use the corrugator supercilii and the procerus muscle. You can see how the eyebrows are coming downwards and medially when the person is using the muscle. Before we go ahead and inject, it's very important. And that's a very important point, right? Because every time the person is using the corrugators and the procerus, the eyebrows are coming downwards and medially, which leads us to believe that preventative Botox or rejuvenative Botox, when the brows are not even coming down, if you start using Botox for the corrugator supercilii and the procerus complex to weaken them early in life, you may be able to prevent the descent of the brow later in life. Now we will move on to injection of. Also, another thing that can be done is the fillers, which is done using the myomodulation technique, and we'll talk more about it. But here the fillers are being injected into the deep to the bone supraperiosteal in the temple area. So essentially, we are going 1 centimeter above the brow and 1 centimeter lateral to the brow and injecting deep supraperiosteally. The idea being that the area where there is a temple hollow gets filled with the fillers. A high G' filler like Juvederm voluma is being used in this particular case, and you can elevate the brow in this particular manner. Now that's the same patient, and you can see immediately afterwards that the lateral brow can definitely be asked to be allowed to kick up by using this. You'll get about 2 to 3 millimeters of elevation using the myomodulation. We've also published a similar paper, but in this case, it's on the tear trough deformity using the myomodulation, in which we've innovatively used a high G' filler, paradoxically, for the under eye area, but injected it laterally. Myomodulation is basically a concept by which you're injecting a high G' filler below the muscle, causing the muscle to tighten up, and thereby exerting effects on the eye, or if, in the case of the brow, exerting the effect of the temporalis muscle on the eyebrow, causing the brow to go up by injecting in the area below the muscle. Another thing that we do very regularly in our practice are thread lifts. We use cog threads for the same, and I didn't have time to fit in the video, but this is essentially how we sort of rotate the thread from the top to the bottom and then from the bottom to the top to raise the eyebrow up. We've already spoken about some of these things. And then there are surgical techniques, of course, of lifting the brow, which a lot of the speakers before have spoken about in detail. All in all, this is what I had to say about brow dynamics. The brow is incredibly important to how the eye and the periocular area looks, and paying attention to it is important. We love to teach. And if you're interested in learning, please do contact us and come in, and we'll try and ensure we teach you as much as we can. And this is a book that was written by a couple of us, 30 of us, and it's an anthology consisting of heartfelt stories by doctors and patients, sort of give every doctor an inspiration in these difficult times when patients want more than 100% results. And this has been on the Amazon bestseller list for quite a long period of time. I thank you for your kind attention and a patient hearing. And thanks once again for allowing me to speak to you today. Thank you.